Cold and flu season is approaching, so we're taking a look at the doors our bodies open to those nasty things. We'll take your calls for all things concerning ears, nose, and throat. The doctors are on call tonight. Funding for On Call is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call, starting its 11th year of opening doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, Regional Health, the Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
Hello and welcome to On Call Television. Today's topic is everything to do with ears, nose, and throat. The surgical specialty of ears, nose, and throat is also called otolaryngology. It had its origins in 1896 in Kansas City, Missouri, when the otolaryngologist called the first meeting of what would later become known as the American Society of Otolaryngology. Oto meaning ear, laryngo or laryngo meaning the upper airways in the throat. Early on, the specialty included the diagnosing and treating illnesses of the eyes or ophthalmology, but sometime in the 60s and early 70s, the field split. And the old doctor known as the ENT or eyes, ears, nose, and throat specialist became the two specialties of ophthalmology and ears, nose, and throat separate. The field of ENT still is very broad, dealing with illnesses of the ears, especially infections in children and hearing loss in the elderly with cancers of the head and neck, nosebleeds, and it goes on and on. Today we have a guest whose special interest involves the care of children with congenital abnormalities, sinus disease in children and adults, voice disorders, balloon sinuplasty, pediatric and adult PE tubes, tonsillectomy, sinus surgery, voice disorders, and cochlear implants. Dr. Greg DeSautel went to medical school at the University of Iowa in Iowa City, did his residency in general surgery and otolaryngology at the University of California, Davis, and is certified by the American College of Surgeons and the American Board of Otolaryngology. Welcome, Dr. DeSautel.
Thanks for having me.
And this has been your second time. I mean, you were on with Dr. Reitz a while back.
Actually with Dr. Bosworth.
That's right, Dr.
About
Bosworth.
Haiti and Dominican Republic.
That's right.
Not too far from trip to Haiti that she had taken, and I've gone to the Dominican several times.
Yeah, so you're still continuing with that Dominican Republic mission.
We are, yeah. We try to go once or twice a year, and it's been a great time. So, I mean, serve a lot of people, but we have a lot of fun at the same time.
Yeah,
so.
That's a wonderful thing that you do. Let's talk about what made you decide to go into ears, nose, and throat.
Well, actually, when I went to medical school, I thought I would be a family physician. I was pretty convinced that's what I wanted to do. And then I started doing cochlear implant research at the University of Iowa when I was a medical student with Bruce Gantz, and that kind of caught my passion, interest, and so then I wanted to be an otolaryngologist and kind of really didn't know much about the field, but realized that it's much broader than ears, and you can deal with both kids and adults, and you do everything from major surgery like head and neck resection all the way down to kind of simple PE tubes, which actually can make a huge difference in kids and adults when it comes to hearing.
So you do peds and adults in one sense?
Yes.
And you did pediatric surgery training too?
Yeah, we did a lot of, I actually did more ear, the last 6 months of my residency actually focused on ears and cochlear implant. So ear surgery in kids and adults is kind of where I specialize, but I do a little bit of everything actually. And sinus now has become kind of a major focus as well.
So cochlear implants, is that done in multiple places in Sioux Falls and Rapid City? Or?
It is, well, I'll brag a little bit on myself. First person to ever do cochlear implants in South Dakota. I did it 15 years ago. Now there's probably one other person in Sioux Falls that does it, and then there's Dr. Moore up in Aberdeen that also does it. Right. So it's pretty specialized. A lot of people go to Mayo or the Boys Town in Omaha.
Well, okay, let's talk about cochlear implant. I have a patient and good friend who has an implant. It took him from complete hearing loss to being able to hear, but he has this implantable noise spreader. Let's hear your words. Spreader?
Spreader.
Noise amplifiers.
Yeah. Well, a cochlear implant is very different than a hearing aid. Recognize that it's an electrode that actually is inserted into the inner ear, and it actually bypasses the normal hearing modalities. And so the one downside of a cochlear implant is you can never go back and use a hearing aid. Once you have an implant, that's really either going to be a benefit to you or your hearing really isn't going to be of any benefit. So that's one thing that sometimes is hard for people to get used to, but the success rate is 90%. And most people, especially as they get older, get very isolated because they can't hear. And a cochlear implant just vastly changes their world. It just kind of opens everything up again to where they can socialize with their family, they can go out with friends, and it just makes a world of difference.
I actually have a second patient who's in her 80s, and she was just totally deaf, totally isolated. And you know, she'd come into my office and you'd just scream bloody murder for her to hear you, and she'd look at her son and he would scream it a second time, and then she could understand it. I don't know what it was. And now with the cochlear implant, she doesn't come in with her son anymore.
Right.
She can understand it. Yeah. I mean, and
that's very common.
So what happens is you put in a nerve receptor. Into the nerve receptors, you put in a...
Right. Basically, the electrode goes into the cochlea, directly stimulates the nerve, which then sends a signal to the brain. What happens on the outside with the speech processor is it actually takes the normal auditory voice and changes that into an electrical signal that's actually then sent directly to the brain.
And how much better are they now than they were when they started and when 15
Huge improvement. Yeah,
15 years ago.
Now the big difference is that we're implanting patients with better hearing because we have better success, and so we do what we call sentence testing, which is where the patients will kind of come in with their hearing aids and they actually get an audio booth, and the best that they can do has to be 40% or less. So, but if they want to be, tested, I would say the one way to know whether you might be a candidate for an implant is if you can't talk on the phone, it's time to actually
be considered.
Yeah,
that's a good way of putting it.
Yeah.
If you can't talk on the phone, no matter how loud you
whatever you amplify, the telephone amplifier, whatever, then you're probably a candidate for an implant.
Okay. Are we making sure that we're putting that telephone number up for you guys to call? We're looking for telephone calls. Questions are what makes this show. So put that number up for us back there in the booth and give us a call. 1-888-376-6225. All right, so there you have it. Give us your calls. So let's talk about the things that we see in the elderly, and hearing loss is certainly a big part of it. And of course, there's that kind of hearing loss due to wax in the canal. Right. And I say the best thing to do is just put a little drop of oil, or you can get wax softener, and you can buy that. The second is that the tympanic membrane is scarred or sick because of infections or whatever. That's something you need to do something about, right?
Typically. The amazing thing about the eardrum is you can have a fair amount of scarring and still have relatively normal hearing. It's when you get the fluid behind the eardrum that patients and adults tend to have trouble. Now, that's less common than people think. I mean, one of the things I always say if somebody comes in and says they have an ear infection, the first thing I ask them is whether they had hearing loss with the ear infection, because a true ear infection, not just negative pressure, is going to cause your hearing to go down. And if that is last for more than 6 weeks, typically we'll put a tube in and correct that hearing loss.
Right, and a tube is a pretty simple deal. You can put it in the office. Now, kids, you don't do it in the office.
Typically they don't want to sit still for that, but that's actually coming. That will be down the road where kids actually probably 2 years and older will actually be able to do them in the office fairly soon. So that technology is almost out there.
You can hold the head still? Or?
They actually use kind of the Apple technology, and they'll actually put little ionophoresis onto the eardrum and numb up the eardrum. And then they actually have the kids watch a little video, almost like, and you know how kids are entranced with iPods or iPads, my 6-year-old is, and they'll actually sit there and watch that. Because there's no pain, they're focused on the video or whatever is playing in front of them, and they'll let you do the tubes. So it's pretty, and it's an amazing thing.
Well, think of the reduction in the cost.
Oh yeah, it's huge. And so, and then, you know, families' time off of work and all of that goes along with having tubes.
But it always, I'm sure that people wonder, I mean, what is it? Just a simple tube in the canal? I mean, you put just basically a tube that goes, here's the canal. You put a tube between the eardrum, and it allows the air to change back and forth, the fluid to drain.
Right. It ventilates the middle ear. Essentially, by putting a tube into the tympanic membrane, into the eardrum, now you bypass the eustachian tube, which actually has to function between the middle ear and the back of your nose. And lots of people
the eustachian tube is that tube that drains the back of the middle ear into the back of the throat.
Nose, right. And so when you have the, you know, allergies or whatever, that causes that eustachian tube then to block up, and that's often why people will get fluid, either from infection, allergies, kind of depends.
So the tubes are something we should be doing more often?
Yeah, a lot of times. I think there are some adults that kind of fear coming in, but yeah, an evaluation and a PET, if you have fluid, a PET tube's pretty simple to fix that problem.
Great. We have a question from Brookings, female with ringing ears for several years. What causes it? So what do you call ringing ears?
Tinnitus, or tinnitus. There's a couple different ways of pronouncing it. Tinnitus, tinnitus. You know, the problem with tinnitus is that it's usually caused from aging. Just as we get older, we lose the nerve function, which is called sensorineural hearing loss. Unfortunately, the little hair cells that usually are supposed to stand up like this, and when they're turned on, they kind of switch on like this, and literally what happens over time with age or noise exposure to another, they actually get kind of half on, half off. And that's why you get the ringing. It can vary. Sometimes it can be pretty pronounced, and then it seems like it lessens a little bit. But that's kind of an on-off switch that kind of gets broken.
Explain that a little bit. The hairs are up there in this fluid.
They're in your cochlea.
And a big, you know, somebody comes down with a trumpet blast, or there's music or a conversation, and it hits the tympanic membrane, and it's reflected with the bones in the middle ear, and then it hits that nerve area, that cochlea.
It hits the cochlea, and then what happens is there's a fluid wave that's generated within the cochlea. That fluid wave, then the endolymph will actually, that fluid wave then causes these little hair cells that are on your in the inner ear there to actually move, and they actually turn on, move with the waves. And depending on where it's at, early on in the basal membrane, you're at different frequencies. The further along you get in the cochlea,
the
lower frequencies. Typically, the higher frequencies are first, and then the lower frequencies as you go along.
Okay.
And so
people who are, the biggest cause for loss of that hearing is
age. Number one. Noise, probably the second most common, especially hunters. Extremely common.
Hunters not putting ear
protection in, yeah. At least when we're young.
How good are those ear protectors?
They're great. Yeah, so the game hunter thing, you know, the ones that kind of actually, when you get a loud blast, they'll turn off the hearing, but you can still hear the birds.
Those are really good.
Yeah, those are worth doing.
What about the pink cheap ones that I've
They work too. Anything you can do is great.
So noise, age is one, too much noise in a lifetime of too much noise, listening to rock and roll when you were young.
Yeah, tractors, I'd say, you know, tractors,
is a big deal.
Yeah, truck drivers, pretty common thing with the window open kind of thing.
And then congenital issues is probably the third major reason.
Yeah, and congenital issues, you know, nowadays with hearing aids or with the cochlear implants, you know, oftentimes we can overcome the hearing loss. But there are some congenital issues that as the kids get older, especially in their teenage years, they'll continue to lose whatever kind of moderate hearing they have, and then they become cochlear implant candidates, or, you know, once hearing aids don't work.
So let's get back to the tinnitus question, or tinnitus. The question I have is, so what can you do for it? In other words, it is a representation of the losing of the nerves. So it really is, when you're hearing it, you know that you're losing some hearing function, nerve hearing function.
Yeah.
So what can you do?
There are no medications that will cure it. And that's what people kind of need to know. There's lots of people, a lot of black magic out there that I call on the market, and you'll see advertisements in the paper and that kind of thing. But there's nothing really that will cure it. Now, there are some medicines that might help you cope with it better. There's oftentimes where depression and tinnitus might go hand in hand. What I see a lot of is sleep disturbance, sleep disorders, people who aren't sleeping well at night. Actually, the tinnitus is exacerbated because they spend all night, all they hear is the ringing.
And so you can treat them with some antidepressants. Sometimes they sleep better.
Yeah, and actually, even if they're not depressed, the antidepressants actually will sometimes help, like nortriptyline or amitriptyline. Yeah. So sometimes Xanax will work, the alprazolam, the anti-anxiety medication, will help as well. That's a very common treatment for tinnitus.
I like the idea of nortriptyline. I'm not a real fan of the benzos because of the long-term side effects of memory loss, and you know, you have to get higher and higher doses. But you know, it's interesting that the nortriptyline, which is really one of our most common treatments for diabetic neuropathy, the peripheral neuropathy, the buzzing in the feet, that nerve problem with the feet is helped by nortriptyline. I used to use a lot of amitriptyline. They're telling us to go toward nortriptyline. That would be helpful for the buzzing in the ears. That's interesting.
The other thing, when it comes to like chronic sinusitis, a lot of people have a lot of chronic facial pain syndrome, and so nortriptyline can be helpful for that as well.
Say that again.
So a lot of people with sinusitis develop what I call a chronic facial pain syndrome. They have the chronic headache, chronic midfacial pain and pressure. Their sinuses are completely normal, and yet nortriptyline works great. So, I mean, you should ask your doctor about that, really.
That's great.
Yeah.
As one of the key senses, good hearing has a significant impact on our lives. If there is a hearing problem, the earlier it is diagnosed, the faster treatment can be begun with the help of technology. We can now test newborns. Actually, newborns only days old.
We screen the babies for hearing tests to check their hearing. It's just an initial hearing test. It just checks their hearing at this point. It doesn't mean that down the road they may not have a hearing problem. It just checks initially that there is no problem. The test involves using a miniature earphone and microphone, which is placed in the infant's ear. Sounds are played and a response is measured. If the baby hears clearly, an echo is returned back into the ear canal, and this is picked up by the microphone. It's best not to do it before 24 hours. They can have fluid in their ear or a little vernix, and that can prevent them from passing. It's best to do it after 24 hours, and they usually pass rather quickly. If they don't pass, we repeat it. We can repeat it several times before they go home. And on an occasion, babies don't pass. It's nothing for the parents to be alarmed about. We have the baby and mom come back in a couple days for a postpartum visit, and then we'll repeat it at that time. And of those babies that come back, most all of them will pass at that time. On a rare occasion that the baby doesn't pass, the doctor will refer that child to an audiologist for further testing. It's very important because if you can catch a child before they start speaking, it helps, with their with their speech. You can get them started right away with some speech therapy or something if there is any a hearing deficit or anything. So it is very helpful that way. This equipment's been around for about 5 years, and before that we had no way of testing their hearing. I've checked my own hearing, and it's just several little beeps and nothing to bother them at all, no.
That's great. It's not a harmful thing. We would be pleased if you got that taken care of with your child. We're very happy that it's happening. So it's a wonderful advancement to be able to check hearing in a newborn that doesn't say, oh, I can hear it now.
Yeah, right. Newborn screening is really important kind of thing, and that really has changed a lot of kids in terms of identifying them early so then they don't develop speech or language delay.
Well, that's right. If you can put the cochlear implant in a deaf baby, right, then they can learn so much faster. And they end up in mainstream school, and usually you put it in about 1, and usually by 2 years of age, they're actually age adjustment basically equal to their peers. So it's pretty amazing. That's an amazing thing. I had a call today from a patient. Actually, he was in my office and we were talking about the show tonight, and he was saying, well, I can't take that CPAP. I was found that I had sleep apnea. I mean, I'm just seeing him, and I know he's watching. And he said, what about those retainer deals? Let's first talk about sleep apnea and then what options of therapy we have. Sure. And sleep apnea, you have to realize, is a continuum. You have kind of a social disorder, which is snoring. Almost everybody with sleep apnea tends to snore. And then you get the wife, and usually the wife will drag the husband in because she's been nudging him, she's tired of having him snore, to the continuum of more of severe sleep apnea, where the patient really has such severe sleep apnea that they're having pulmonary hypertension, they're at risk for heart attacks, that kind of thing. So, the only way to really diagnose sleep apnea is with a sleep study. So that's the first step. You have to have a sleep study. The other thing is that if you have mild to moderate sleep apnea, you tend to do better and be maybe more of a surgical candidate. The retainers, where they pull the base of your tongue forward, may be more effective. I really say for severe sleep apnea, the best treatment is CPAP. I just try to use, there's several different masks out there now. If they just can't tolerate that at all, then there are some other options. But for people with moderate to severe sleep apnea, I really push the CPAP. Well, it's life-saving. I mean, these people's lives are changed. They come out from a person who's just sleepy all day long, and their blood is sky high, and they have an early heart attack and stroke, to a person who has a normal life again. Right. Well, and we think that Reggie White, the famous Green Bay Packer, that he probably died from sleep. I mean, he probably had sleep apnea, and that's why he ended up with a heart attack. Most heart attacks happen at night while you're sleeping, and so, it makes sense it's probably caused from sleep apnea. So, Greg, my patient said, okay, so I think this retainer deal, this is the way to go, except that the people who had to sell that to me was $2,000, and I've got some friends who say they got a $200 one on the internet, and it worked just as well. What do you know? That's a pretty tough question, because I will say it's better to have something that's specific for your anatomy and that's going to work best for you. But they are expensive. They are between $600 and $2,000 in terms of the actual cost. I usually tell the person to check with their dentist first. If there's somebody that they trust, and if the dentist doesn't do it, maybe they can refer them on. There's lots of dentists now that are becoming more and more interested in this field, because a lot of insurance companies are now going, if CPAP doesn't work, they'll actually require you to do a dental device to pull your tongue forward before they'll authorize surgery. And so it's becoming more and more commonplace. And surgery is effective in the right individual with the right indications. And you don't know of any real cheap method to find a device to position your mouth? No, I don't. And you're not recommending? No, I'm not recommending going on the internet and going. Although, maybe, I don't know. I don't want to underestimate, because the reality is there probably are some people that are benefited by those $200 devices. I would just say the vast majority probably are better off spending a little bit extra and getting what really works. Okay. A question about earwax. Let's talk about earwax. I know that tons of people come in and you'll look in their ear because they do I have earwax in there? Mm-hmm. And you see that it's been smashed into there, and you can see the trauma to the canal by the Q-tips. So let's talk about Q-tips. I was told that you should use Q-tips only after 90 years of age, and before that, the smallest thing you should put in your ear is your elbow. There you go. I'm not quite that I will say there are lots of people that use Q-tips and they do just fine. There are certain people though where they get half the wax in and half the wax is still in their ear canal, getting pushed closer and closer to the eardrum. So my usual recommendation for somebody is just to actually leave their ears alone. The wax is natural, it's supposed to be there. Most people can live with the wax that they're being produced, and just taking a Kleenex and just wiping whatever wax they can get out with the Kleenex after a shower kind of thing.
The other thing that's real effective is actually a combination of alcohol and vinegar. Just get a little eyedropper, use alcohol and vinegar, and you can actually mix it with a little bit of water, 3 equal parts alcohol, vinegar, and water, and use that to flush the ear out. The alcohol will dry the ear, vinegar keeps it acidic so it doesn't get infected, and the water just cuts it so it's not quite so strong. But that's my usual recommendation. When hydrogen peroxide also works.
Yeah, so I've heard that, and I've done that. I actually have done that combination of vinegar and alcohol for people who get swimmer's ear.
Right.
If they do that before they go swimming and after they go swimming and they don't have the swimmer's ear problem.
Right.
Well, and that's an external infection. That's in the canal.
Right.
And the other kinds of infections behind
In the eardrum. Right.
behind the eardrum. But what about the just plain earwax softener or oil, sweet oil, or vinegar, mineral oil, or
olive oil. Yeah,
olive oil.
Any of that can work and is sometimes beneficial. Now, the trouble that I see sometimes with the cerumen wax removal is they'll soften the wax, and the wax tends to then coat their eardrum. So sometimes it works, and sometimes people have to come in and still have it cleaned out, kind of thing. I see lots of people with wax impactions. There's nothing more satisfying than someone cleaning out, somebody's can't hear, and then all of a sudden they leave your office hearing. You feel kind of
makes
like a miracle worker.
Yeah.
Not quite, yeah.
So we have a whole bunch of answers there for you. My son has a ranula that has been drained once and has come back. What should I do now? What's a ranula?
Ranula is basically a mucocele. It's a fluid-filled cyst that's in the floor of the mouth that's right down underneath the tongue that tends to be. Sometimes you have plunging ranulas that will actually kind of keep moving down, but they almost all need to be excised, and you have to excise every bit of the wall, otherwise they will keep coming back. And sometimes you can call them ranula or mucocele. They happen kind of in the lower lip for people, in the floor of the mouth, and on the tongue, but they really need to be excised. Draining almost never works.
And it's not a dangerous thing, except that it.
Yeah, it's not a dangerous thing. It's just bothersome. But they almost always need it taken out. And even the surgery is very safe. The greatest risk really is that it's going to come back.
So you generally numb it, clasp it with a forceps, and then cut it out and then sew it together.
I wish it was that easy. It actually takes a fair amount of time to dissect out the sac around the, it takes a while, probably between 45 minutes to do it. Yeah. And you should be asleep for it too. So.
Yeah.
It's a lot better tolerated.
Because there's a lot of blood.
There's a lot of blood,
yeah. All right, airplane is descending, gets bad pain in the ears. What can I do?
There's something called ear planes that I really actually recommend for a lot of people, and you actually put them in. You can either put them in before you leave the runway or in the middle of the air, and there's basically what they do is help to equalize the pressure. You just put them in. They're a little ball valve. They're called ear planes, EAR planes, and they work pretty well for people, and especially with people with severe eustachian tube problems. I recommend just putting them in actually before they take off, and then leaving them in until they land, and people use it.
But it doesn't correct the eustachian dysfunction.
No, but it helps to allow them so they don't have to equalize as much with their eustachian tubes.
That swallowing thing.
That swallowing thing.
So I'll give you an airplane story. It's the same thing that happens to me periodically when I go on an airplane, and then they shift the pressure, and then suddenly I have these stabbing facial pains that just explode. And I mean, I had one after an airplane ride that was sort of like the worst pain I've ever had in my whole life for about an hour.
Yeah.
You've had that same thing. So because of that, I'll have Afrin, which I hate. I really don't recommend that, except that I will spray it down with a 12-hour nasal spray that I think we should teach people not to use, except when you go on airplane rides.
Yeah.
What do you think about that?
I think that's totally appropriate. The other thing I do use is Sudafed. 12-hour Sudafed I think can be effective as well. So I'll have them use Afrin, and if somebody's really severe, I'll have them take a Sudafed, like first thing when they wake up in the morning, depending on when their plane ride is. So those two things I think are real helpful. I like Afrin when people have colds too for 3 days. As long as they don't use it for 3 days, any of the nasal decongestants is relatively safe. So
I've said that you can use an Afrin nasal spray once or twice a week max.
Oh yeah.
But people don't do just 3 days.
No, they don't. They tend to use it every night, like 1 or 2 sprays at night before they go to bed, and then they'll come into my office asking how we can get them off of it. And there are some ways we can do that, but usually it does require a procedure.
Steroid
oftentimes.
nasal spray.
That helps, but patients don't tolerate that very well. They won't stop the decongestion and take the steroid spray. That just doesn't give them enough relief.
I burst them with prednisone, I give them the steroid nasal spray, I say no more Afrin, and I give them pain medicines, And they still are using it, is what you're telling me.
Yeah, most of the
time. So what
time.
procedure do you use?
In the office, we can actually shrink their turbinates down with a co-blader. There's lots of different ways now where you can just numb them up with some lidocaine in the office.
Cut down the nasals.
Yeah, and then you just put a co-blader in there and it causes a little bit of scarring and atrophy of the turbinate, and that tends to work pretty well.
So I cannot deep sea dive. I tried it about a year ago and my whole face imploded just like that airplane ride.
Yeah.
I'll never be able to. Try the Afrin.
You should try the Afrin, but you don't really want to. You know, and some people, the downside is tubes would actually work pretty well in that situation. But then, if you have tubes in your ears, then you can't scuba dive because you don't want to get the water in there, and you have all kinds of problems. So, yeah, there's no good.
Live without
scuba diving.
Just snorkel.
There you go.
Here's a call from Watertown Airplane. Oh, that was the last one. Here's a call from Sioux Falls. Saw you, had a stapedectomy 2 times, told to get hearing aids, 1990, University of Iowa. Doctor took bone from behind the ear, worked well for a while. Is age related to the deterioration of my hearing in the operated ear?
If I get the gist of the question correctly, yes. A stapedectomy, usually if you get a good result.
So what's a stapedectomy?
Stapedectomy is actually replacing the 3rd little ear bone that ends up, you know, you've got 3 bones, the malleus, which is on your eardrum, the incus, and then you have a stapes that moves like a piston in and out of your cochlea. People have what we call otosclerosis, and that stapes gets fixed, so it no longer moves. A new bone forms, and it's just like the piston in your car. I say that it ran out of oil. There's no oil there anymore. It can't move. So the stapedectomy replaces that stapes. Usually we use a laser, put a piston in there that'll move in and out of the inner ear now just freely. And so we've replaced that 3rd ear bone.
So it's just amazing to me that here we have the canal, hits the eardrum. There's these 3 bones in this middle ear area that kind of accentuate the noise and moves it into a movement piston situation, which shoves the sound into waves where all these nerves pick up these hairs pick up the waves.
It's pretty incredible.
It's incredible.
It is.
So a stapedectomy helps always or a short period of time. This person's apparently it's getting worse again.
And it's that the person who called in is exactly right. Stapedectomy will help, but unfortunately it's not going to keep them from having the normal age-related hearing loss, the inner ear nerve loss that we all tend to get as we get older. And some people are more prone to it than others. There's a genetic predisposition to hearing loss of aging.
So it's interesting to differentiate between the hearing loss of aging, which is involving the cochlea and the nerves, the kind of hearing loss that happens when you're okay when you're alone or with your wife, but when you're in a room, you can't understand a word anybody's saying. Right. The noise is lost, the differentiation between high and low goes away, and it's all one sound.
Right.
That's one kind of hearing loss. The second is when you have a stapes that's not moving or there's an infection in there, and all it does is it turns down the volume. Right. And the hearing aid really works well for that group, but doesn't work for that first group where the nerve loss is bad. And that's what this person could do. If they're finding they can't understand in a room, it's not the stapedectomy that's a problem. It's their nerve loss. Right.
And they may actually, depending on the severity, they could still benefit from a cochlear implant potentially. If they're wearing a hearing aid, it's not helping, they want to consider going to the next step.
And if they can't hear on the telephone, that's the time to try the cochlear implant.
Right.
Wow.
Exactly.
I have another one from Sturgis. Ear surgery. What is the surgery called to have you hear better? Where they would do it and how much does it cost? Okay, so that's it. We're talking about the
Well, we're talking about, now that question actually is very broad. I mean, because it's not just stapedectomies that can restore your hearing. Let's say the incus is absent. Let's say you've had infections, and I see this pretty commonly where the 2nd ear bone has, because of loss of blood supply now, it's fractured, or so you can replace that. The eardrum might have a large hole in it. Even just replacing or fixing the hole in the eardrum might improve the hearing. So, you know, that may cost anywhere from $2,000, probably minimum, up to maybe $4,000 or $5,000, depending on the exact procedure.
Okay.
So
that's one. That's another surgery. I mean, there's a bunch of surgeries for hearing.
Yeah.
What's the most common one?
Tympanoplasty, or a hole in the eardrum that we have to repair with a graft. The most common probably would be PE tubes, but beyond that is to repair a hole in the eardrum. And sometimes that's a result of having PE tubes in your ear. So.
But it's most commonly because of recurrent infections, right?
Typically. Although I will say, actually, it's probably I'd say the most common reason for a hole in the eardrum is a PE tube that's been in there too long. And we probably should mention that. If you have a PE tube and you leave it in longer than 2 years, your risk of having a hole in the eardrum goes way up. So if you have kids, or even you as an adult has a tube in your ear, you should at least consider having that taken out after 2 years, just to prevent the hole in the eardrum.
But if you have a hole in the eardrum, it's kind of the same story as having a tube, right?
It is a little bit, except when you have a PE tube in there, because of the surface tension, you can swim, you can get your ears wet a lot easier than when you have a hole in the eardrum. If you have a hole in the eardrum, you can't swim. Kids can swim with PE tubes in, and they don't have to worry about earplugs.
Oh.
Because they have surface tension that keeps the water out of there, and so they're a lot less prone for, a lot less prone for having ear infections. So I let my kids that have tubes in their ears swim without earplugs.
But not in a lake.
Not in a lake. You're right. Okay, you got me there. I'll give you that.
But skiing, you know, water skiing is such a joy.
Yeah.
How about if I just plugged my ear with these
little wax? That works fine.
Oh, it does.
Oh yeah.
So I can go skiing?
Yeah, you can go skiing with a little earwax, yeah.
Gotta have but where do you get those things?
Doc's earplugs, you can just get them at any pharmacy.
Oh.
They're just over the counter.
So ear surgery, what the surgery that makes the ear better? One of them was the
Stapedectomy. One of them is the tympanoplasty, which is grafting the eardrum. The other is saccular reconstruction, where we actually replace typically the second ear bone.
Okay, and then finally it's that nerve implant with your
the cochlear implant. Sure.
From Brookings, would an elderly man be eligible for a transplant? Nerve is only working 30%. So is there a transplant? I guess it's...
I think they're talking about a cochlear implant. There really isn't any kind of transplant procedure, like you have a corneal transplant or that kind of thing. Really, nowadays, it would be the cochlear implant I think they're talking about.
And that's the question, and the question is, it's indicated when you can't talk on the phone. Yeah. The second question, though, is who's eligible? What's the cost? And who pays for the cost?
Almost every insurance will pay for cochlear implants, including Medicare. I'd say the average patient who maybe is over 65 who's on Medicare, they may pay anywhere from $100 to $200. Now realize a cochlear implant, the actual cost is between $25,000 and $30,000 just for the implant. The surgery itself, if you add in the OR surgical fee, post-op rehab, is probably $50,000 total. But Medicare is very good about reimbursing for that. And so are most insurance companies.
Is a 30% hearing loss enough?
Yeah, it depends on if it's actually just 30%, probably not. If it's 70% hearing loss, then yeah, they're probably a candidate.
Now, and that's the other question when you look at hearing loss pictures. Hearing loss, here it is. It's the low pitch, the middle pitch, the higher pitch, the higher pitch, the higher pitch. And what you do is you see typical hearing loss is they lose out on that high pitch.
On the high frequencies.
And that's the noise.
And that's why when you have background noise, high frequencies are important to help us with background noise. And that's why people, when they go into restaurants when there's lots of background noise, they can't tend to block that out now. And so that's when they tend to have lots of trouble. And there are hearing aids that are better now because they're digital, they're programmable, and they can help to amplify just the higher frequencies. The thing that you kind of mentioned before, though, is if you don't have good discrimination, if you can't understand the words, it doesn't matter how much you amplify it, you still can't understand the words. Right. Our discrimination is lost, and that happens sometimes more or less in certain individuals.
Say that again. Discrimination is that you can't define the high pitch from the low pitch. The high pitch is gone, everything muddies together.
Yeah, a little bit. Now, realize discrimination is your ability to understand words. So if I tell you cowboy, you understand the word cowboy as opposed to, let's say, cotton or whatever. But then there's that differentiation with background noise too, which adds to the problem. So it can be a little bit complex, and that's where I try to tell patients who come in and they don't wear their hearing aids, I say, the reason you're not a good hearing aid candidate is because we could amplify the sound to as loud as we can get it, and you still won't understand the words.
All right. That's 1-888-376-6225. That's 1-888-376-6225. Give us your calls. Let's run through a bunch of questions. This is great fun. Peer recommending alcohol. What type of alcohol and what type of vinegar should be used to put in your ears?
Yeah, straight rubbing alcohol, 70%, and just the acetic acid right off the shelf.
And then a glass of wine to go with that.
Yeah, absolutely.
Like Preston, is it safe to do ear wicking? Ear wicking.
The first time I ever saw somebody who had ear wicking, and this was probably now almost 8 to 10 years ago. It's pretty safe, although I will say the first one I ever saw had lost their eardrum. Somehow whatever they had used to protect the eardrum had moved, and the wax went down onto the eardrum, and they actually, when they pulled out the candle, pulled out the eardrum with it.
All right,
so I'm not a big fan of it. Well,
explain it to me.
It's a candle. It's a candle. They light the end of the candle. The heat then causes some type of process where the wax is literally kind of pulled up into the candle. It's a little bit hokey. Okay, I mean, it is, because there's lots of people that it feels good to have the heat and the warmth in their ear canal, but they may or may not have any wax to begin with. So, you know, it's not harmful. I do think there is some benefit where it will actually draw the wax out, but the vast majority of people I see probably don't really need to have it done.
And there's some danger, because you can burn a hole in your tympanic membrane. You've seen one.
I've seen it. It doesn't happen very often, but yeah, I know what happened in this case.
Yeah, so. I just like the idea of using a little, you know, olive oil. You have it in your kitchen pan. Drop that in, it'll soften the wax, and then it'll drain off on your pillow at night.
Right. Yeah. Save the $25 or whatever they charge for the ear candling. I think
who does that ear candling?
There are lots of people that actually. I'm not sure where they get it done, but there are lots of people who advertise it. Maybe the beautician. I don't know. So.
Here's from Lemon. Thanks for calling, Lemon. I have chronic sinusitis and have been advised to look into surgery. When is surgery indicated? Let's talk about sinusitis.
Okay.
What I think a lot of people come in and go, I've got sinus problems, or I've got sinus now.
Yeah.
I want an antibiotic.
Yeah.
What's your comment about the use of antibiotics for sinus infections or sinus symptoms, or what is sinusitis?
Yeah, and that's very kind of confusing for a lot of people. Most of the time when somebody comes into the office, especially if it's in the first week, they basically just have a cold, common cold that's viral induced. It actually does affect their sinuses. So you do have the pressure, you have some congestion, which are, people often think, well, I have a sinus infection. And it's true in one sense, but really it's viral induced. So what you have to first understand is that most colds, most things that involve the sinuses are viral, and they won't be benefited by antibiotics. Lots of good studies that say no difference between, and I know you've been preaching that for years,
yes.
And it really is. Patients don't recover any faster on an antibiotic or off.
They don't feel better.
They don't,
In fact, then they get diarrhea problems, and then they get overgrowth infections.
And it actually is pretty well known that there are probably greater risks to being on an antibiotic than not taking one, in terms of just because of the resistance, the GI side effects, and especially things like fluoroquinolones like Levaquin. They have tremendous amount of side effects with rashes and arthritis and that kind of thing.
So avoid the antibiotics for chronic sinusitis, except?
Well, avoid the antibiotics in the situation where you're in the first 7 to 10 days of symptoms. Again, nasal congestion, nasal drainage. If you're having yellowish green drainage and discharge that's been going on for more than 2 weeks, an antibiotic is,
try it.
2
weeks of drainage?
2 weeks. Realize, and chronic sinusitis is actually really the diagnosis or is made based on the fact that you've had symptoms for 12 weeks. So think about that. Chronic sinusitis, the true definition is 12 weeks of symptoms of chronic congestion, chronic nasal drainage, mid-facial pain and pressure.
And you know, when people have severe pressure up here and here, I suggest they stop blowing their nose hard. Now, Dr. Reitz and I I'm going to say this because he and I have had this long conversation.
Yeah.
I read in a New England Journal of Medicine article or somewhere that you can develop 100 pounds of pressure by blowing hard. Yeah. Particularly if you close off one nostril and blow really hard. Not a great idea, I think, particularly if you want to ram that, unless you're wanting to ram all that mucus into a sinus and then cause pressure and pain. And then I'd suggest sucking on lozenges so that you're constantly swallowing and making saliva, which is a powerful anti-infectious agent, and then draining it that way.
My recommendation actually is I like a nasal decongestant, either oral or Afrin for the first couple of days, and then doing a sinus rinse or a sinus wash. I actually am a big believer in the neti pot or the Nelmed thing. I mean, it's pretty well known that that's going to help if you have postnasal drainage congestion. Those are real effective. And things like Flonase or fluticasone, the nasal steroid spray.
I'm a real fan of the steroid nasal spray.
You know, it's very low side effects and it is often very beneficial.
Okay. I think we've beaten that one to death enough. What do you think about nasal irrigation? Well, that's a very question.
Yeah.
But I've had a patient who did it twice a day, hard, pushed hard. I'm thinking there's some side effects and problems that can occur from too much of it.
Yeah, I would say it's a love-hate thing. About half the patients I recommend, I think, love it. The other half hate it because either the fluid ends up in their ears or it ends up, and what I often will hear is, 30 minutes after I did the sinus rinse, I leaned forward and I got this gush of water, which kind of is socially not very acceptable. No. Yeah, so they get embarrassed.
I wanted to, we have some information from Lon Keitlinger about the West Nile virus, and actually what we needed to talk about is influenza. He's saying it's time to go for the influenza vaccine. And so get in and get your flu shot. We've already got some cases of flu shots in this state, or flu happening in kids, so it's going to be an early season. So get your flu shots now. Here it is, we've got it now, right? 4 confirmed cases of influenza already been reported in South Dakota. All 4 were children, and 1 child was less than 6 months old. We've got the influenza vaccine available. Get in and get your flu vaccine. Any comments?
I agree, yeah, it's absolutely critical.
All right, my 11th-month-old had 5 ear infections. At what point should we consider PE tubes?
Usually my criteria is if the kids are on antibiotics more than they're off, it's time to start thinking about doing PE tubes. Usually 6 to 9 ear infections in a year, but that gets to be an awful lot, and usually we do them a little bit more frequent than that. If the child doesn't get better with antibiotics, and they have to be a little careful because the typical ear infection, the fluid will last 6 weeks beyond what you have an acute ear infection. So, just because Johnny or Sally has fluid in their ears doesn't necessarily mean they need more antibiotics. Time may take care of it without doing anything.
So, right, not antibiotics for ear infections. I mean, what are you saying? This is heresy.
Yeah, well, and again, I think there are certain indications where antibiotics may be effective, but for the vast majority of kids, antibiotics aren't, I hate to say this, but I don't give my own kids, when they have an ear infection, I give them Tylenol and ibuprofen, and the numbing drops actually can work really great. The benzocaine.
Can you buy those over the counter?
You have to get a prescription, but your regular doctor will be happy to do that typically. If they diagnose you with an ear infection, the benzocaine drops work great.
Ooh. All right, let's talk about a flat tympanogram and an ear infection. What is a tympanogram? What's a flat tympanogram, and is it useful?
Tympanograms are good because they will tell you if the eardrum has normal mobility, what you'll see is kind of a nice spike at 0, okay? And the tympanogram is just putting an ultrasonic wave on the eardrum. It's not painful. It helps to confirm that there's fluid in the middle. It doesn't tell you anything about what type of fluid it is. It could be mucoid, which means that it's just thick. It could be purulent and not infected. Could be purulent. But a flat tympanogram, if it has low volume, typically means there's fluid. Now, you can also have a flat tympanogram because there's a hole in the eardrum, and then you'll have a high volume. And sometimes doctors get a little confused about that, and sometimes even myself, I'll say, well, you have a flat tympanogram, but I don't look at the volume, and I don't realize, it's actually a hole in the eardrum.
And it's not fluid.
And it's not fluid. So.
And you don't typically always treat fluid behind the tympanic membrane.
A lot of times just leave it alone and watch
Try to get the eustachian tube to function.
Right, and it's really time is your best friend. You can, I don't want to, I say there's chiropractors, but honestly, time is your best friend. There's very little else that you're going to be able to really do to make a difference there.
Give it a little time. And I like the idea of throat lozenges. If they're too young, you don't want to give them throat lozenges and they inhale them. But
right.
Vertigo started in February. Sudafed helps. Specialists can't figure out what to do. Help.
Yeah, that's a pretty common thing. I actually would do a PE tube in that patient.
Put in a PE tube.
They probably have a mild form of Meniere's disease, which is but typically sometimes people with eustachian tubes are real sensitive in their inner ears. And I've had lots of people, we just put a PE tube and it makes a world of difference.
Vertigo is a big problem. People have dizziness and it's a big problem.
But recognize vertigo as a true diagnosis of room spinning. Yeah. It's not lightheaded. If you stand up and you feel lightheaded, that's something different. That's probably,
you need to come to the ENT.
Yeah, you need to go, absolutely.
And I don't have a good answer to that either. No, I do. I really do.
Yeah.
Yeah. Here, M-tryptophan, trigeminal neuralgia, neuropathy, amitriptyline.
Amitriptyline.
Oh, amitriptyline, trigeminal neuralgia, neuropathy. Would nortriptyline help for neuropathy? Nortriptyline's basically the same as amitriptyline, and it's less side effects. Probably a better option. So if you're on amitriptyline, talk to your doctor. Say, how about nortriptyline?
Yeah.
Brookings' daughter had perforated eardrums. Should we go for a third surgery? What would happen if she didn't have the surgery?
You know, there are lots of people that live their whole lives with a hole in the eardrum. So third time around, I actually will look at the amount of hearing loss that's associated with that eardrum perforation. And there are times where I'll honestly tell the parents, I said, if it were, you know, I treat everybody kind of if there's my grandmother or my mom or me. And sometimes you don't need to have that fixed. If it's just, you know, the risks sometimes outweigh the benefits, and that's what you always are weighing whenever you do a surgery.
Depend on your doctor.
Yeah.
All right, well, we'll be right back after this. Here lies a tale of mystery dealing with the occult. An 80-something-year-old gentleman came into my office a few months ago with a new lump on his neck. It didn't hurt, he had no sores in his mouth, and he noted nothing else unusual except that he had been recently widowed and he missed his wife terribly. On exam, there was a hard lump behind his ear and jaw, measuring about the shape and size of an olive. My initial exam of ear canals, hearing, nasal passages, mouth, tongue, and throat found him to be normal. His voice was clear. There was no palpable irregularities of the trachea, which was positioned in the midline of his neck. I sent him to the ears, nose, and throat specialist to take a direct look with a scope at the back of the nose, the throat, the vocal cords, and to remove or biopsy the lump. The scope exam was clear, but after the biopsy of the lump, the microscopic exam brought the diagnosis of metastatic squamous cell carcinoma of the head and neck with occult primary. In other words, his cancer started from skin-like thin sheets of cells that commonly line the upper airways, and the term occult is medical lingo for a cancer that has spread from another site, but the original primary site remains a mystery. I remember another case of a metastatic cancer first discovered in the brain, but on autopsy, the occult primary was from the lung. The medical meaning of occult is nothing mystical or magical, just unknown and sometimes devastating. Well, looking for the source of such a head and neck cancer, I did some research and learned of the following risk factors for squamous cell cancer of the head and neck: exposure to excessive amounts of alcohol, tobacco, smoke, or chew, wood dust, fine nickel and metal particles, formaldehyde, preserved or salted foods, pan, which is an addictive leaf or nut chewed in the Southeast Asia, and bitter mate, a tea-like beverage sipped in South America. Our patient is a typical retired college professor originally from a farm on the South Dakota prairie with little tobacco, wood industry, or travel history, only having lived a dedicated life helping students and savoring time with his wife. For now, after removing the nodule, we've provided no other treatment. Our patient is doing fine, and still the origin for the cancer remains occult. We didn't talk about underlying cancers and cancers of the head and neck very much yet, Greg. Any comments about that?
Well, in terms of, you know, head and neck cancer, I think what's becoming more and more known is that the various types of cancer, if they're HPV positive, in other words, they tend to be more responsive to radiation chemotherapy. And so what's more responsive to radiation chemotherapy. So less likely that surgery is going to be of as much, well, not necessarily, it's going to be a benefit, but we're going to tend to recommend radiation and chemotherapy in those patients.
And that's the kind that is from a wart. It's a
yeah,
wart
typically
inside.
HPV virus, we're all exposed to it, and it's usually in our tonsils a lot of times. And I would bet that this occult cancer probably did start in the tonsil. Base of tongue, tonsil, those are probably the most two common areas where primary cancers that we can't really see initially, we end up locating.
Wow.
But you know, we're doing lots and lots more research on that.
All right. Well, that closes our show on ears, nose, and throat. I sincerely thank our studio guest, Dr. Greg DeSautel of Sanford Ear, Nose, and Throat Clinic in Sioux Falls for helping answer all the wonderful questions from our audience. DeSautel. We'll leave you with a thought from Oliver Wendell Holmes. Friendship is the breathing rose with sweets in every fold. Until next time, stay healthy out there, people.
By
There
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call, starting its 11th year of opening doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, Regional Health, the Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.